Good evening. I'm Stephen Bleeker, CEO and founder of Assurance Home Care. Along with my business partner, Christine McGinn, we're delighted to welcome you to this evening's panel as part of Briere Month. Here at Assurance, we feel so honored and proud to be part of this cause that's so near and dear to our hearts. It's really what we do every day, helping individuals to do more than just remain in their home, but to really thrive on their terms with highly customized one-on-one care plans. At Assurance Home Care, we know that investment in research at Briere drives the evolution of patient care, both at Briere and across Canada. Every day, researchers at the Briere Research Institute continue to find new ways to maximize quality of life and help people stay and return home. As our population ages, these investments will only become more important. We are proud to partner with Briere this September and encourage you to support this important cause by visiting bemovedtogive.ca. Thank you.
Welcome to our panel tonight. It's great to have this amazing turnout. So tonight we're going to be talking about palliative care in Canada. And to start us off, I just wanted to provide a brief definition of what is palliative care. Many of you probably already know, but according to the WHO, palliative care improves the quality of life of patients and that of their families who are facing challenges associated with life-threatening illness, whether it be physical, psychological, social, or spiritual. And palliative care also often includes quality of life of caregivers who are supporting patients. So access to palliative care has been an issue globally for the last several years. Worldwide, only about 14% of people who need palliative care receive it. Unfortunately, we don't have a statistic that quite matches onto that for Canada. However, we do know that the vast majority of people prefer to receive care at home towards the end of life, and that in Ontario and Alberta, only 1 in 6 patients receive access to palliative home care. So the numbers are really drastic. We've assembled together tonight a really intelligent and compassionate panel of individuals who live and breathe research and care in palliative care. And we're going to talk to you about care across the country, but also innovations in research that we're working on as researchers and caregiver advocates and clinicians. So my name is Serena Eisenberg. I'm the Briere Chair in Mixed Methods Palliative Care Research, and I'm also an assistant professor at University of Ottawa, University of Toronto, and Johns Hopkins University. My research focuses on examining access to palliative care for marginalized and non-cancer populations, and also looking at ways to improve access and quality of care. So the way things are going to work tonight is I'm going to introduce all 5 of our wonderful panelists, and then I have questions prepared for each of them, and they're each going to take approximately 5 minutes to respond. So that will take us to the first half hour of tonight. Then after that, the floor will be open to questions from the audience. I also have a couple of additional questions prepared as well that we can get to if needed. So to get started, our first panelist is Denise Lynch, who is a caregiver advocate. Denise's healthcare experiences span more than 20 years, including caring, advocating, and navigating for her dad, husband, and others, oftentimes the complex elements of our healthcare system. Denise is currently a caregiver advisor on 2 of my research projects, and I've had the pleasure of collaborating with her over the past year. In addition to that, she's a founding member of the Patient Advisors Network, and she is also a member of the Regional Central East LHIN Steering Committee in Palliative Care. So moving along, we also have Dr. Shirley Bush, who is an attending physician on the palliative care unit at Briere. She's also an associate professor in the Department of Medicine at University of Ottawa and an investigator at the Briere Research Institute. Her research interests include delirium management and guidelines and the impact of delirium on patients and their families. Next, we have Dr. James Downer, who is a critical care and palliative care physician and the head of the Division of Palliative Care at the University of Ottawa. Dr. Downer's research interests include communication and decision-making for serious ill patients and their families, and palliative care for the critically ill. Then we have Dr. Peter Lawler, who's an attending physician on the palliative care unit at Briere. He's a professor in the Division of Palliative Care and Department of Medicine at University of Ottawa. His research interests include cancer pain assessment and classification and cognitive dysfunction, particularly delirium in palliative care. And we'll hear more about that later tonight. Finally, we have Dr. Peter Canasaputro, who is a public health and preventative medicine specialist. He's also an assistant professor in the Division of Palliative Care and an investigator with BRIA Research Institute. He currently practices family medicine in the community with a focus on palliative home visits. And his research focuses on using linked health and MIN databases to develop population perspectives on healthcare use and outcomes associated with aging and end of life in Ontario. So we've got a great mix of researchers and clinicians and our wonderful caregiver advocate. So we're really excited to chat with you tonight about what our work has found and where we see this field going in the future, both in terms of research, but also clinical care. So my first question tonight is for Dr. Peter Canasaputro. So a really broad question to start us off. What is our understanding about palliative care in Canada as it stands right now?
Thanks, Rena. Excuse me. And thank you everyone for attending. I see a lot of familiar names on the attendees, and I hope we can go through this pretty quickly so that we can get to the questions, because I think it's really important to open up a dialogue about this, right? And I guess my first point is exactly that, a dialogue on death and dying. I think the first point that I wanted to make is that we all feel that Canada, and Ontario and Ottawa, no matter where you go across Canada, we live in a death-denying society. I think a lot of people say that, that we don't like to talk about death and dying. We get uncomfortable talking about death and dying. We, brush it under the mat and hope that it doesn't come, that the dirt doesn't come up when you lift up the mat. But invariably, it always does, right? And to be honest, I feel like clinicians are the worst culprits, right? I think clinicians, I don't know. I practice as a primary care physician, and I have obviously a lot of colleagues who practice in the hospital setting, oncologists, respirologists, cardiologists. And the general consensus is that it's hard to talk about death and dying, right? It's hard to open up that Pandora's box. And when you open up that Pandora's box, the truth and the reality is that, it is, quite a whammy to talk about, right? And, there are a lot of issues, a lot of fears, a lot of insecurities that come with talking about death and dying. And so clinicians, try to avoid the discussion, right? And it does no one good. One example I always bring up is the example of a teacher in the Netherlands. So this Dutch teacher, she was, I think, around 40 years old. She was dying of cervical cancer, quite terminal. She had only a few weeks left to live. And as one of her dying wishes, she wanted her students to make a coffin for her in the home economic class, right? I'm gonna read you the quote from what she said. Okay, I pulled it up just now, so I'm not making this up. So she said that life and death belong together. The children realized that when I explained it to them, I didn't want to be morbid about it. I wanted them to help me. I told them where I will go is much nicer than this world. And I see that as an incredible story, because you can only imagine if someone tried to do that in Ottawa, in Toronto, no matter where you are listening in from, it just will not work, right? We're not comfortable in this society to talk about death and dying, even though it is as certain as life, right? And we always say that a good death is part of a good life lived, and it's so true, right? And one of the misconceptions about what we do in palliative care. So I care for my patients who are dying in their homes, and I do home visits. And to be honest, it's the most rewarding thing that I do throughout my week. And helping people to find that meaning and to help people find that fulfillment and that closure in their dying process, and to connect to families and loved ones. I think there's no larger gift really that you can give people who are ill. But, and there's a big but here, and I'm a researcher. I use big data to look at what we do in society. And one of the things we looked at, I think Srina alluded to it already, is how often do we provide that care, right? And how often do we provide that care in the home where patients really want to be? It's pretty insane and pretty crazy that patients who are dying, we ask them to come in, go to the hospital, pick up their wheelchair, have family members come and accompany them. And so much time is wasted, and so much time is taken away from patients, in my opinion, where they should be being cared of at home. And we all know that it's very costly to care for patients in the hospital setting. No one wants to be in the hospital. It's a win-win situation, quite frankly, right? And in Canada, the statistic is that 52% of people die in acute care hospital. So not Briere, not St. Vincent, TOH, right? Queensway Carleton. And in acute care beds where we really should be not providing the end of life care. And a lot of people end up in one of our projects that we've done with James, for example, looks at ALC beds. So these are beds where people are just waiting for an outside bed so they can be transferred outside the hospital. And when people are dying, they are in these beds occupying precious resources and being in a place where, especially with COVID, visitors can't come, they can't connect with their families, and it's just absolutely tragic, right? So what can we do about it? Palliative care. Palliative care is the answer, end of life care. And James and Shirley are palliative care specialists, and Peter Lowry is a palliative care specialist. I would be lucky if one of them cared for me when I'm dying. But the reality is that only 1 in 10 will see a Peter, James, or a Shirley, right? The rest of them just cannot. There's just not enough of them. And so part of the solution, I really truly believe, is involving generalists, so family doctors like myself, to provide that care, right? And it's pretty insane that I can ask the participants here, how many of you know if your family doctor does home visits? If you are dying, God forbid, will your family doctor visit you in your home? I bet you most of you won't know, right? Because it is quite haphazard. We need to start making palliative care really systematic in terms of what you do as a primary care physician, and to deliver that care in the home. And Serena alluded to, our research alluded to, only 1 in 5 will get a physician home visit in the last year of life. And it's just kind of like what color house you live in. That's the analogy I use. It is quite random depending on whether your family doctor will be willing to do it. If you end up in hospital, whether or not do you think about involving palliative care, et cetera, et cetera, et cetera. I probably went over my 5 minutes. I wasn't watching, Serena. Am I over 5?
You are like 2 minutes over. So
okay, I'll stop. Okay, because part of the solution is prognostication, but I'll let James take that one.
Okay, so thank you, Peter. It's a really helpful overview. So James, my question for you is, how can we change the landscape moving forward, ensuring that more people have access to palliative care, both in Ontario and nationally?
Yeah, I mean, it's a really good question you were asking, and I'm looking mindful, like Peter, of some of the names that are on the attendees today. That I think we're clearly not speaking to a crowd of novices here. I think that when we talk about access, and there's many different dimensions to capacity building, right? So there's getting the sort of highly specialized, palliative care specialists, or people who do palliative care, only palliative care for a living. But realistically, there's just no way to build a system where literally everybody in Canada who dies is going to be seen by one of these people prior to their death. I mean, that's not realistic, right? So you have 270,000 Canadians died last year. It's going up. We have a few hundred specialized palliative care physicians. If every one of us could clone ourselves, 10 times over, we wouldn't come close to being able to achieve that. And I don't think it's achievable, and it's probably not even desirable, right? So you're building capacity in many different areas as well. And, GPs, this is something that's part of general practice. It's not something that should be considered the exclusive province of the highly specialized. But I think for one of the other things that we need to recognize is that sometimes it's not even about access, right? In fact, it's hard to measure access or prove that it's good or bad. But what we can tell is that even people who have access are getting it later than they should. And I think one of the really important barriers we have is not so much whether you see palliative care, whether you have palliative care initiated, but that it's done in a timely manner. What we think of as being the right time for a palliative care consultation or palliative care involvement is really anyone's guess. But right now we know that most people, your sort of initial contact with palliative care, if you get it, is going to be in the order of a couple of weeks before you die, 3 or 4 weeks. probably it should be earlier than that, closer to many months or even a year, probably for most people realistically. So how do we get there? A lot of it is that, the way we make decisions is that we're very reactive. So we're gonna call palliative care when literally like the house is on fire, everything's fallen off, and all of a sudden, you're on your fourth line of treatment that isn't working for an underlying condition, and somebody says, have you had a conversation with palliative care? And everyone else says, oh, we were waiting for someone to bring it, and you often find yourself in the point of saying, geez, so why didn't somebody say this before? And you can wring your hands. And I think this death denying society is a real factor here. But there are many times where I think you would be pushing an open door if you did it a little earlier. And we definitely need to stop, I think, relying on typical human decision-making to be able to pick out people at the right time and deliver that care. We're becoming increasingly aware of assisted decision-making, automated means of prompting us. And it's not necessarily artificial intelligence, but it's what we call augmented intelligence. So the same way that, I know how to drive a car. Many of us know how to drive a car, but there are certain very predictable mistakes that people make when we drive cars. We cut people off, we have blind spots, we back up into things. There are very predictable ways in which we get into accidents. And so people have been developing, things like, the backup alarm on your car, the lane change alert when there's a car in your blind spot. There are ways that computers can nudge us to be aware of dangers that we're not very good at recognizing. And it's the same thing in end-of-life care. That actually there are many good, very accurate models out there that use data that's already in our computer systems about us that can tell us, roughly on a population basis, who is at higher risk and who than the general population of dying in the next year, for example. And so, coming up with systems that can rely on that type of modeling in order to help nudge us, right? Whether what your exact prognosis is less important than if you're at a high risk group. Maybe that's somebody who we might want to spend a little extra time with, right? Sort of saying, hey, look, I don't know exactly how long this person might have, but if they know it's relatively short and they have some unmet palliative needs, maybe we can start to address those needs. And maybe it's less important precisely how long they have, just the fact that they're in this high risk group, right? So instead of waiting for culture change, instead of waiting for people to make that transition, we nudge them and say, hey, come back and look at bed 14 again, right? Like, because this person actually has a bunch of things that predict that they might not do well over the next year. And maybe we should have a conversation with them about that. And what we found from our early pilot work that we've done is that actually these models work really well. They identify people very accurately. And many of these people actually do have unmet palliative needs that we can address. And we've got a number of large pilot studies going on. One of them looking at one in the inpatient setting called Homer, which is now being rolled out at about 20 hospitals across the province. We've got another one. We've got other endeavors going on across the country. And then Peter and Amy Shu are leading one called Respect, which is based on data that can be used in the home care setting and in long-term care. So again, you can see that, as we move forward with technology, the ability to use not even particularly advanced technology, just to help nudge us, to help us remind us to do the right thing in certain specific situations, because we know that these are areas where our own decision-making may be a little bit weak. And then as we start to train physicians and start to be able to actually talk to patients about it, here's an ability to actually personalize it, bring it to the bedside for very specific people. So we train people up to have goals of care conversations and treat symptoms, and then they go home. And we know that from a lot of studies that it's taking doctors and nurses to classroom and teaching them all kinds of skills, and they all check off the box saying, this was the best course I ever attended and I loved it, and then please could I do it every week, this is awesome. But very often they go back and just do exactly the same thing they were already doing, and it doesn't often drive culture change. So take that education, pair it with situational prompts at the bedside, and create this, rather than waiting for culture change, you kind of nudge it and drive it along. I think that's really important. I was going to also talk just really quickly about some of the symptoms that we're starting to get into as well. Like one of the things that I think we've been really interested in as medical assistance in dying has become legal in Canada, driving a greater awareness of what drives this, which seems to be existential distress, a problem we've known about for a long time, but probably didn't maybe recognize as being as big of a deal as it really is. And understanding, of course, that we don't have a ton to offer for it. So starting to study newer therapies and trying to maybe change the way we look at distress as a whole. Existential distress has many different definitions, but broadly speaking, it's about people feeling distressed with where they're at and what they're able to do and how it's different from their expectations and what they feel gives them their life meaning and worth and fun, right? And if you know that you've got an illness that's taking that away from you and that illness is progressing rapidly and not going to turn around, that can create tremendous distress among people nearing the end of life. What if we could find new ways to help people with that, right? Like we don't necessarily have to be able to fix the underlying illness or give you back the abilities that you've lost as a result of it. Maybe all we need to do is help with newer therapies that might change how you look at that and reduce your distress. So we look at things like transcranial magnetic stimulation therapy and everyone's favorite topic these days is psychedelics, psilocybin, magic mushrooms, and what those can offer us as really legitimate therapies to help reduce distress. And we're seeing some very promising early results in that front and very excited. But I know you have other people to talk about symptoms here, so I'm going to hand the microphone back to you and let you turn it over to them.
Thank you, James. So James started the conversation on symptom management. And, you know, as I mentioned, both Shirley and Peter Lawler are palliative care clinicians in Brière's palliative care unit. So I'm wondering if you could speak to some of the challenges in clinical care and also drawing on your research, if you could talk about some recent developments in symptom management research, for example, focusing on the work that you two have done in delirium.
Thank you, Serena. Shall I start, Peter? It's kind of a duo doing delirium work here, which has been really good for me. Working with Peter has been a great partnership to improve the care of our delirious patients on the unit. And for people who may not be familiar with delirium, maybe I can just describe it as a neurocognitive disorder. It is acute change in our patients. So a confusion that's very sudden in onset and can fluctuate. So that differentiates it from dementia, which is a more chronic change. Having said that, patients who are at risk of delirium tend to be older people and those who already have dementia, as well as patients who have advanced illness and are much closer to the end of life. Hence our interest in palliative care, because research has also shown that up to 88% of patients will develop delirium before they die. So that's in the last hours or days of life. So it's extremely common. And that's really, I find it very fascinating and why it's so important to improve our care. Because we know delirium is also distressing for patients, distressing for family caregivers, and also the staff looking after them as well. So this is why I wanted to know what can I do to improve this? And about 5 years ago now, my colleague Peter Lawler was involved in an Australian randomized controlled trial looking at antipsychotic use in delirious patients in a multi-site center study in Australia. And that study showed that the patients who received these medications called antipsychotics, which we used to use particularly to try and control delirium symptoms, particularly if they were agitated, the patients actually did worse. They had worse delirium symptoms and maybe potentially died even sooner. So this really turned the palliative care world on its head to see, well, what can we do we've now got this research, what can we do to improve our care? It's also known that it can take up to 17 years to put research that's published into practice at the bedside, which is an awful long time. And I wasn't going to wait for that. We need to do it quicker. So I used the tool of developing a clinical practice guideline to bring this research much quicker to the bedside so that the staff can use it and improve the care for our patients and family caregivers. So as part of that, we have implemented the guideline. And I also created a patient and family information leaflet on delirium as well. So it's a bilingual leaflet. If anyone's interested, you can access it on the Brière.org external website. If you just type in delirium in the search window, you'll find it. So I give it out a lot. And if I could just share a story, because delirium, I didn't also mention, can fluctuate between a patient being very agitated. So that's very easy to recognize. And also a patient can be very withdrawn and quiet. So that delirium is often missed. So we had a patient and her husband was there. She'd been extremely agitated overnight, was calm by the next day. So that typical fluctuation. And I brought in the information leaflet to give to her husband, but he said he didn't need it. So I thought, okay, I've got it here in my hand. Let me give it to the patient. And she's actually seems to be able to talk to me fine today. So she took it and was looking at it. I left the room. I happened to pop back into the room about 15 minutes later because I just wanted to check on something else. And she was actually reading it to her husband. I just found it fascinating. She was saying, you need to tell me where I am and who I am and what day it is. And so she was reading him out to him and how to communicate in short, simple sentences. So I found that quite fascinating. She died quite peacefully 2 days later. So the delirium is often a warning sign that people die soon. But I just thought it's really a tangible thing I can give to patients and family caregivers to help them understand delirium better and help improve their care. So I continue to work on this area to improve our non-pharmacological interventions, which is making sure we're orientating patients and keeping them hydrated as well as possible, mobilizing them where we can. But I've also been working with Peter on using maybe some emerging medications, and Peter, maybe I'll hand over to you to talk a bit more about that, and also the other research collaboratives we've done with our work.
Sorry, I was muted. Thank you, Shirley. I really appreciate your anecdote. That was a powerful little story there. And I would reiterate what you've said about the whole issue of medications being used to treat delirium. Certainly, there's been a bit of a paradigm shift in terms of medications used. There is an increased focus. We'll always probably need some medications to treat delirium at the end of life, but there is an increased shift on the use of non-pharmacological interventions. I'm not going to talk too much about that, except to say that conducting research in this population is very, very challenging. They're a very vulnerable population. There's all sorts of ethical issues in conducting studies at the end of life when somebody is very close to the end. It is really quite challenging. It can be done, and we have done it, and we will be doing it, but it is challenging. And one of the ways that we get around these challenges would be to collaborate. It's very difficult to do a large study in one center. So we look at collaborating both nationally, even just regionally in the city, but nationally and internationally. And I've had a long involvement with the Australian group. And as Shirley said, the study that we published back in 2017 did cause quite a stir. So it made people think a lot about non-pharmacological intervention. One of those interventions, I suppose, again, we can't always get away from some pharmacological intervention. But one of the interventions that Shirley and I looked at would be the use of melatonin. And we conducted a feasibility study on the use of melatonin to prevent delirium. Melatonin is a sleep hormone, so it's available over the counter. We just conducted a feasibility study. We're also waiting to finish an Australian study. Both of us are involved in it. And the prospect is that we're looking at conducting a study in Canada that would be conducted through the Pan-Canadian Palliative Care Research Collaborative. Dr. Downer and Dr. Bruno Gagnon and some others have initiated this clinical trials group, and we would hope, pending the result of the Australian study in melatonin, to consider looking at a melatonin randomized controlled trial in Canada. Again, that would be multi-center. The other intervention that I thought I might talk about is a medication called dexmetatamine. Dexmetatamine is an alpha-2 receptor agonist that has been used extensively in intensive care. Not very much in palliative care. So we are involved at the moment in conducting a feasibility study looking at the use of dexmedetomidine in palliative care. The big advantage of using dexmedetomidine, as opposed to some of the other medications that Shirley had previously mentioned, is that dexmedetomidine allows rousable sedation. Many of the patients with the agitated type of delirium that Shirley referred to do require some sedation at the end of life. So families really find this very difficult, not being able to communicate with somebody. So dexmedetomidine certainly poses the potential advantage of being able to rouse somebody. It gives some sedation, but it also allows the rousability factor so that families can communicate with them. They're just two of the studies, but again, I would emphasize the whole issue of collaboration and national and international involvement to try and get successful studies completed.
Thank you, Peter and Shirley. That is extremely helpful to learn about the really rich research program that you two have built on delirium. And thank you, Heidi, for sharing in the chat the link to the delirium booklet that Shirley mentioned. So we also have a very different perspective represented today, and that is of the caregiver advisor. So as we know, palliative care ultimately impacts the family and caregivers who surround the patient. So Denise, I'm wondering if you could share your perspective on how we can ensure we are integrating patient and family caregivers in research and care.
Well, it's been great just to sit and listen to all these specialists and their areas of expertise. From my perspective as a patient advocate, it's kind of twofold. One, I cared for my loved ones, and I still carry on that. I've cared for them across the continuum of care. So while you experience, and most physicians may experience it within a silo, we go from silo to silo. So we're starting to see, and we have been observing, where some of the gaps and barriers are in terms of palliative care. From a patient and a caregiver perspective, I'm going to agree with Peter, who talked first about the definition, you gave the definition, Serena, but talked about what people think of when they hear the word palliative, and it's immediate death, and nobody wants to talk about it, and it's scary. I've looked at it because I've been advocating for a very long time. I've looked at it as helping people to live their best quality life based on their capabilities until they die, because death is the event, but you're living until you die. So how do I ensure quality of life, whether it's a loved one or a patient? And those conversations need to be focused on both the patient who is palliative or has a life-limiting condition, and the family. It really boils down very simply to a couple of things. It's communication, and it's listening, and it's looking at, while I look at the medical side of palliative care, it's to control symptoms so people are comfortable and not in any pain, but it's also informational. Because when you're treating an individual, you're treating a patient, you're treating their physical symptoms, but you're also touching on, because we're composed of a spiritual side, an emotional side, and an informational side. And I find, and I've experienced it myself, it's fear and not knowing. What's this going to be like? And because they lose so many abilities as they're facing end of life, for my dad, it wasn't any one particular ailment or disease that took him. It was aging, pure and simple. And I saw, when I thought he was needing palliative care, perhaps before the long-term care home where he was in, realized it because I was paying attention. He was my dad. I knew what he needed. I knew what he liked and didn't like. And I really believe that education and sharing information with caregivers helps them to do the practical things while they're caring for patients at home, while they're caring for their loved ones. And so it's not always a doctor we need. It's maybe a social worker. It's maybe somebody who can say, here are some resources where you can get some more information on what your dad or your husband or whomever, what they're going through and experiencing, and things you can do to help them be more calm or continue to enjoy life. Because if you can control the pain symptoms, life can go on, and it can still be meaningful, because that's what people are searching for when they know time is limited. It's traumatic to get the diagnosis, because my father died of old age, and I could see he was leaving slowly but surely, the decrease in eating and the sleeping, but he was cognitively, he was there. With other people that I've advocated for, it's a shock. And I've gone with them to an appointments where they've received that news. And it's a traumatic event for them, and it's a traumatic event sometimes for the advocate who's with them, because your brain kicks into, oh my God, this is not good news. And it becomes, they stop listening. The blood pressure goes up, the stress hormones flood the system, and they really need a bit of time to understand and process the diagnosis. And they need help sometimes in understanding, how can I cope with this on an emotional and informational and spiritual level? And, I recognize that while that seems very simple, those really are important ingredients. They're the most important. If you can get the physical under control, and you can deal with the emotional, mental, informational needs that people have, life does go on, and it can be good right until they draw their last breath. What this does for the family and the caregivers, they remember that last period of time they have with their loved one. And it's easier to deal with the grief and the bereavement that come along, because you had a hand in helping them live a good life till the end. I like the words that I heard used by some of you, that word thrive, and that's what it is. They thrive. You want them to thrive to the best of their ability. And with our aging demographic, life is a series of losses. As we age, we can't do what we used to do, maybe can't eat what we used to eat. The biggest social life we have is with our medical professionals. That's where we're getting our kicks these days. And I want my medical professionals to be happy. I don't think anybody gets up at the beginning of the day and says, I want to see how I can really make my patients suffer today. Nobody starts off with that. You're in that field because you care about people, because you want to make a difference. But I think if we can just have some real conversations, that's critical. And it's about listening, and it's about helping the caregiver, because for them, it's most traumatic, almost in a way, a little bit more traumatic than it is for the patient. And here's why. For the caregiver who is going to be left after their loved one dies, they kick into gear with, oh my God, what's my life going to be like when I lose this person? I have to start all over. They won't be here. How am I going to cope? So giving them confidence and some tools and information to deal with their loved one goes a long way towards helping them deal with the grief. And there's also anticipatory grief, which I don't think we've paid enough attention to. When someone receives a diagnosis of a life-limiting illness, you start thinking about, and you almost are into, it's an anticipatory grief, knowing that that person will be leaving you. You maybe not know the date, but they're not going to be around for 20 years, or maybe even another 5. And I think those are key parts. All of this to say, it takes a team. It takes a village to raise a child. It takes a team of people to help a person who is going through the dying process. And palliative care is not about dying. It's about living well until you do die, and helping the families and the caregivers, whether they're, immediate blood relations or their chosen family and friends. So I don't know if I've gone over my 5 minutes, but that's kind of my take in a nutshell. And I really appreciated listening to everybody's perspective, because, hey, we're all on the same page. So thank you.
Thank you, Denise. And I've got to say, it's been a real pleasure being able to collaborate with Denise over the last year. She always brings really, really sharp insights into our studies and helps us to make sure that what we're doing is patient and caregiver centered at all times. So now we're going to open the floor to questions. And I see we have a comment from Rob Alino, who says, thank you, Denise, or Ron Bellino. Thank you, Denise, for sharing some of your story, experience, and wisdom as a caregiver / patient voice, some sage advice. So I could not agree more with Ron. Denise, we're very privileged to have you with us today.
Well, I want to give a shout out to all the caregivers who may be listening in. You need to ask questions of your care providers so that you can know best how to deal with your loved one and do for your loved one. We need to be assertive in that way. And because they want, I mean, all our medical professionals, they want to help us, but they don't always ask or have the time to ask the right question. But that could be our role as caregivers.
Certainly. So Denise, while we have you unmuted, I have another question for you. So you've been, as I said, working with me for the past year on projects, and I know you've collaborated with some health professionals as well. What were some of the challenges you anticipated when you first began partnering and collaborating with researchers and health professionals on health system improvements? And I guess what have been some of the benefits that you've received from this work?
Well, the benefit is we're all human beings and we all share a common focus, and that's to improve things. So it's not about you didn't do this right or I didn't do this right. It's about here are the gaps. What can we do to move that forward? Some of the challenges were the amount of knowledge that everybody I see on the screen possesses and I don't. I'm an expert in the lived experiences, but as you know, when we've had our different meetings, I'm saying, could you translate that for me, please?
Yeah.
Because you are stepping into a world that you don't know. You know because you receive care and you receive treatments, but some of the acronyms and so those were some of the challenges. But I have to say, I found people, as I say, human and more than willing to share what they know or give me an interpretation so I can understand where they're coming from and what it means, because only then can I be helpful in terms of asking more questions or bringing up a point or making a suggestion. And yeah, it's our humanness that really is the benefit, and knowing that we have that single focus of improvement.
Certainly. And for those in the Champlain region, Janet Dumbrack wants to remind you that the Champlain Hospice Palliative Care Program offers a 5-week basic skills training program for family caregivers. And if you're interested, the contact person is Brittany Saburin. So I've heard really wonderful things about that program. It's excellent training, and they really prepare you in a holistic way to provide support to your loved one. So the next question we have is from Sophia Oroz. Wonder what the different panelists think about volunteers supporting the person who is dying or their care partner, especially those who do not have family or friends to support them.
I'm going to jump in and I'm going to say there's nothing better than having people in your community surround you and offer help if they can. But I think you have to know the patient and or the other caregivers that may be around. So everybody's different. We have to remember that. And the type of care or volunteer work you may want to do, I would seek some training. I know there's training out there for volunteers in hospice, and I would suggest that so that you really know what you're stepping into.
So I will say that I actually used to be a volunteer on the palliative care unit at Bridgepoint in Toronto, and I found it to be an extremely rewarding experience. But I obviously had a lot of background into palliative care when I was volunteering there. So I am curious to hear from our clinical colleagues about their perceptions of volunteers. And I see, James, you have your hand up.
There we go. Yeah, I mean, I think it's obviously, as we talked about, like, I think the large majority of Canadians want to be able to die, certainly not in an acute care setting, and many of them not even in any kind of institutional setting, but at home. I think that has to be our aim, should be to try to provide that wherever it's feasible and wanted. And I think we are some distance from being able to do that. I think it's important, though, to include in that discussion the fact that there are definitely situations where it's not possible. A very cynical way to look at it would be that, every time someone achieves a home death, what that means is that we found a whole bunch of unpaid caregivers to leverage, because nobody is able to, very, very, very few people are ever able to get all of their end of life care at home and die at home if they live alone and have no social support, right? If they're sort of socially deprived, that's just not a realistic prospect. And that is increasingly the situation for a lot of people. As we move towards compassionate communities and a structure that provides that kind of support, that will be more feasible for more people, but we are some distance from being able to do that. And I think it's important not to put unrealistic expectations on people, society, et cetera, in general, to achieve things that are not realistic or even safe. I think our aim should be incremental change and getting things slightly better as we move. But we have to recognize we have a long way to go here. It's not just about home care funding, that's for sure.
Certainly. So in that vein, I'm wondering if our panelists could talk about, any new practice or policy developments that will improve access to and quality of palliative care. I know we've sort of alluded to a couple of research innovations that are happening, but I'm thinking at a broader scale, what can be done? What are some of the improvements that are happening or we hope to happen?
Yeah, I'll jump in, Serena. I was gonna, before you ask that question, I was gonna echo James's comments, because I completely agree. Like, it's just not feasible to die at home if you don't have someone who's there, to be honest, 24/7, and that's the reality, at night, during the day, someone needs to be there. And, one point I do want to make is that, yes, you will never get that hospital deaths to zero, but, I think it's definitely reasonable to get it down much lower, right? And I always bring up the fact that the death rate in acute care hospitals in the United States, is 29%, right? And I already told you that here in Canada is 52%, right? So for all the things they get wrong, I always say that they figured out that it's actually that patients want to stay at home, and it's actually, and I say this, cynically, but it's actually cheaper to keep people at home, right? To provide that care in the home, because the most costly care that you'll ever incur is in the hospital. If you go to hospital, the acute care hospital is truly set to try to cure you, even if you're imminently dying. That's just how, I think obviously I say that, bluntly, but, we've gotten better, but, it is set up to, to try to treat whatever you came in with, right? And sometimes it's reversal, but do you really want to reverse it if death is imminent? Or do you really want to focus on quality of life, right? So that was my point. And the other point I want to make is that, acute care hospital and home are not the only two options, right? And if you don't have palliative care involved and you don't have, the end of life care planning, you will die in acute care hospital. But there are places like Briere, palliative care units. There are hospices. I always say to my patients, if I'm gonna die, I want to die at home or hospice, and just leave me alone. It's one of those two. Because I've seen what care is like, or PCU, and because PCUs are wonderful too. But but I do not want to die in an acute care bed. I think there's this misconception that it's either home or acute care bed. It's definitely not. I think there are way more appropriate places, including in institutional settings like hospices and palliative care units. To answer, I know you asked a question, Serena, so sorry to just hijack that, but I really want to put that in there. The other thing, in terms of advances, I'm biased. James and I, work on the Respect tool and the Homer tool. If I'm going to put actually the Respect tool, the link on the URL there on the chat, we released a tool that helps people identify how long they have left to live. Again, as a way to open up conversations about death and dying. We've gotten, since the last 2 months or so, about 800,000 hits of people using it. So there's been really good uptake. And I always bring up this analogy, that I don't know how many of you have Netflix or how many of you shop on Amazon, but Netflix will tell you what show you want to watch next, right? Based on your previous data. Amazon will tell you pretty accurately, what you want to buy next or what you might buy next based on your previous purchases. Why can't we in this day and age, in digital age, with the amount of reams and reams and reams of data that we collect in healthcare, use that data to help people with their journey, right? What can you anticipate next? What can you, how long do you have left to live? Should, you ask your family members from Vancouver to fly over to say to say their goodbyes. We have all that data, believe it or not, death, sometimes not predictable, often and very often is. And the steps of senescence, that aging process is somewhat predictable. I think, I forget who mentioned it, might have been you, Denise, people, spend more and more time in bed. People spend, lose their ability to eat, lose their ability to go to the washroom, right? And there's a process that's of senescence that's predictable. And why do we not use the data, to not just, do you have heart disease, do you not, but, this kind of functional data, right? The aging process of the body, not wanting to eat, not wanting to drink, wanting to sleep more. Why don't we use that data to help people with their journey? And I think we're slowly figuring out that we should be using that data. That's my answer, Serena.
I'm going to build on what Peter just said and talk about, I think it's virtualhospice.ca. When my dad was dying, it was very sad, and I was in anticipatory grief. And it's like, okay, what is this going to look like? And I went on virtual hospice. I think it's a program developed out of Manitoba. I got lots of really good information, especially in the middle of the night when I couldn't sleep. I'd have things rolling around in my head. And information is so powerful. It takes the mystery out of so much, and it helps you to prepare yourself. So my 2 cents for what it's worth.
Yeah, I completely agree, Denise. And, I think that was you who brought it up. Sorry, I'm just jumping in, Serena. But a lot of times when I do my palliative home visit, all I do is sit and listen, like you said, Denise, and tell them what's going to happen, and tell them what to expect. And then, I always give my cell phone numbers, and, for people who can text, to text me. But, often a single text, that takes me 10, 15 seconds just saying, okay, is it, should I go to the ER or not? Is it normal or not? What should I do? Like just little information, little tidbits, and, telling them what's going to happen, assuring them that they're not going to be in excruciating pain, right? Holding their hands and walking through that journey with them, and being that person that say, okay, if at 7 p.m. you run into crisis, you have me to count on. I think that's such a big part of palliative care. It's not, part of it obviously is prescribing and symptom relief and all those things, but the biggest value I feel like I add, in patient's home, is just being there for a person, right? And perhaps it doesn't have to be a physician. I think you're right, Denise. It could be perhaps a different profession, right? And we've heard of, professions like death doulas, right? I don't know if many people have heard about that, but I think we need to be there for people, right?
What we're doing out in the central region, Central East region, is in developing a strategy for palliative care. Some of the areas like Scarborough and whatnot, they put together palliative care teams. So it doesn't always have to be the doctors or physicians. They have social workers, they have nurse practitioners, they have nurses. And sometimes, as you said, it's just that ability to share or give information that makes a world of difference.
Definitely. And, talking about different providers in the home besides the physician. So a couple of years ago, myself and Dr. Amy Hsu, who's also at Briere, did a study on looking at end-of-life home care. So for those of you who don't know, the Local Health Integration Network, which is now Home and Community Care Support Services, has a package of services, a suite of services that's called the End-of-Life Designation Package. And so if the clinician determines that the patient is towards the end of life, this package can get activated, and includes specialized nurses who are trained in palliative care, specialized personal support workers, and it also includes additional hours of support that is provided beyond what the typical home care package is. And so when thinking about policy developments, we found that an investment by the government of $995 per person who was receiving that end-of-life care package would avoid one hospital death. So $995 is less than 1 day in hospital. So it's minor investments, minor policy changes that can really lead to huge structural changes. And these are the kinds of things that we're advocating for. Myself, Peter Tanasaputro, and James Downer are all involved with the Ontario Palliative Care Network, which is essentially an arm's length government entity that advises the Ministry of Health. And through that, we're able to at least try to get our research into the hands of policymakers and decision makers. So I'm wondering, we've talked a lot about what's currently happening in the research space. What do you see as next steps in research to support improvements in access to palliative care in the upcoming years? Like, where's the future of palliative care research going?
I can try to take a stab at this one if you want.
Sure.
I mean, I think it's important to recognize the changing demographics, right? It's the old Wayne Gretzky quote about don't skate where the puck is, skate where the puck is going. As you look at what we're doing well, where palliative care is actually being delivered, it is clear that palliative care is still very much a cancer thing. The overwhelming majority of palliative care resources, palliative care consultations, visits, etc., are delivered to a segment of the population that is dying of cancer, which is not to say that they don't deserve it, because obviously they deserve it, but that's only 25% of the population. 75% of the population gets very little, almost nothing, and when they get it very late, or not at all. What we need to do is dramatically increase the involvement of palliative care in those in populations that are not our traditional populations. So that might be non-cancer, multi-morbid conditions, that might be frailty conditions, and making sure that we're meeting their needs. Now, it's also important to recognize that much of our treatment, a lot of our decision-making paradigm isn't the same in non-cancer populations as it is in the frail. So we have to have ways of prognosticating and having goals of care discussions for people with conditions that aren't all that predictable and with which the population might not be all that familiar. So there's a lot of work to be done in that area. I think that's a key part of it. I think that we also need to recognize, again, that COVID has taught us an awful lot about the limitations in our system, particularly in long-term care. We have to look at long-term care as not, I think it's gotten a really bad name even before COVID as kind of a warehouse where we put our elderly to save money. It's not a place that's considered a desirable or even a tolerable location to be. We have to change that. We also have to make sure that the care we deliver, particularly the end-of-life care we deliver there, is of high quality, because we certainly learned that there were a lot of cracks in the system. I'll stop there.
Thank you, James. Well, we're almost at time. I'm wondering if anyone has any parting words before we close out. That's really helpful to get a sense of the vision, and as you say, focusing on diseases outside of cancer as really the new frontier in palliative care research. So from Ron, I love and use the Wayne Gretzky quote as well, James, skate to where the puck is going, although it was Walter Gretzky coined that and Wayne shared it. Very interesting to know. It's great to bring this forward thinking perspective into palliative care. Well, I think I'll let Ron have the last word tonight. And I thank you all for attending tonight. I want to give a huge thank you to our panelists who shared their expertise and experiences with us. And, we hope that you'll continue to be engaged in learning more about palliative care, and certainly feel free to reach out to us if you're interested in getting involved in the work that we do. Thank you all for your time. Have a great evening. Bye-bye.